Adam rapidly rose through the ranks. He was an assistant professor of medicine at SUNY Stony Brook. A little over a decade, we recruited him here. He was immediately promoted to associate professor of medicine at USD, and then professor, I think 2010. And now he stands in front of you, chief of cardiology and leader of a large academic program quantifying the impact of technique on clinical outcome in the context of cardiovascular events. He's going to talk with us today about transcatheter aortic valve replacement and emerging innovations in cardiology. So Adam, thank you.
Thank you very much, everybody. This is a great opportunity for me, an honor to speak on such a date. Dr. Talley was a very valued member of our cardiology division faculty, especially for the fellowship, and a great teacher. Today we'll talk about, if I could have my slides up, please. Maybe I'll get them up myself. Good. They should project on this screen. They're projecting all screens except for the main one, which is unfortunate. Okay, very good. So talk about near future, which is actually now in interventional cardiology when it comes to the, thank you, innovation. In interventional cardiology in our field, there have been quantum leaps every few years, and the last 3 decades have been amazing. Disruptive technologies, techniques, new devices and treatments to the better of our patients and population. I have no conflicts of interest to disclose, and the technological progress is the main theme of this lecture. What we'll be talking about is mostly concepts, general concepts, because of lack of time to go deeply in detail for studies supporting those. However, every technology that I'll discuss is present in the US or very near to be present. So in interventional cardiology, we're always dealing with near future, which becomes future very fast for us. And we hope that with the innovation, cardiovascular disease dipped in 60s and 70s and started to come down when it comes to number of deaths in the country from its cause. First, I'll talk about the transaortic valve replacement. What it is now that the valve is very well set, that the valves are put percutaneously very routinely. However, near future has expanding indications, expanding populations of patients for this technology, as well as new valve generations, better, slicker, more effective, cheaper. Transaortic valve replacement, minimal invasive procedure. We do it for severe aortic stenosis, which is the most common severe valve disease. And for those that are inoperable or high risk of surgery. However, already now there's good studies showing that intermediate risk of open heart surgery patients benefit from those valves compared to the patients that have transcatheter valve. In a similar manner as the first trial for the transcatheter valve showed differences in total mortality, major adverse cardiac events, and even stroke. And these were high-risk population patients. So the future is that we'll be doing more and more TAVR on the less sick patients that require new valve. 2 valves. One is balloon expandable are on the market now. This is a 3rd generation already. When I'll try to be practical here for our internal medicine doctors and primary care physicians, as well as students and residents. I will talk about what you will see on the charts on your patients. So you will see sapient valve, balloon expandable, 3rd generation already, which is very fast when it comes to FDA. 4 years, 3 generations of valves were approved. That can be used, or another valve, this self-expanding valve called core valve, nitinol frame. We decide which valve a given patient gets depending on anatomy. You don't have to worry about it. But some patients would qualify for both, some patients would not. It depends on the anatomy in the heart as well as anatomy in access site. Access site nowadays is mostly transfemoral. We go through femoral artery, And we don't go anymore through heart apex as we used to a few years ago, or make an incision in the chest and puncture the aorta, ascending aorta with a needle through surgical incision to put the valve in. Valves are slicker. Femoral arteries almost always can take them nowadays. And I don't recall when we did last one, not transfemorally. Also, we do those valves with percutaneous approach, so there's no cut down anymore. There's no scalpel. There's just percutaneous sutures that we put in. Many valves on the horizon. Coming in. A third valve that we're part of the trial is called Portico. It's yet better than its predecessors, and coming in this year. As you can have about 15 of them around the world in trials or approved. I think Europeans have 7 varieties at the moment. Not just when it comes to TAVR, there's also other techniques that are improved. The percutaneous stitch method, with two of these devices used in a cross fashion, that patients basically can stand up and start walking 2 to 4 hours after the procedure, as well as devices to improve the deployment of the valve. Imaging advances when it comes to cardiac MRI, CT, advanced cardiac CT, as well as 3D transthoracic and transvaginal echocardiography. Enough about the valves. Our valve program has been very well from the start. We are, of course, benchmarked against national registry and part of the registry, and we do very well when it comes to device success, as well as mortality, as well as when it comes to length of stay. So we are doing very well from that perspective. The TAVR is the reason why biological valves put in surgically will predominate now. So you will be very rarely seeing new patients coming to you with mechanical aortic valves. The surgeons now put in biological valves into even young patients, knowing that if the valve wears out, mechanical valves wear out way longer than the biological valves, they will be putting a valve in valve to cure that problem. So if a 42-year-old patient comes in with rheumatic aortic stenosis, a surgeon will put biological valve, either a pericardial cow or big valve, and knowing that in 15 years it will degenerate, but even now we can put valve in valve and do a TAVR on those patients. So rarely you will see mechanical valve newly put in your patient nowadays for this reason. Next technology is absorbable stents. You know that there's lots of varieties of stents that can be confusing, but actually it's not that complex if we take a bird's view approach. So first, absorbable stent that absorbs completely from your coronary artery is here. There's more to come, of course. We started with stent platforms of first metal stents, bare metal stents, then drug-eluting stents, and we have a second generation drug-eluting stents, which are hard to beat by anything new on this market. Then we went into fancy polymer and drug only on the luminal side of the stent, like Synergy stent. Didn't beat the second generation stents. Then we went into drug-filled stents. There's no matrix. Matrix is the substance that the drug is embedded in and elutes, from which it elutes into the vessel. We think that this is matrix can be evil because it can cause inflammation, thrombosis. It can disrupt and cause an increased plaque formation. So there's a drug-filled stent that didn't pan out too well neither. And then there's first bioabsorbable, fully bioabsorbable stent. The theory behind this stent is very appealing, at least theoretically. That is, we can restore the vessel to a more natural state, capable of natural vascular function. Vasomotion is restored, and that's proven by studies once the stent is fully absorbed. Then for future bypass or future stents, we have a free-of-stent vessel to work with. You know, some of your patients have 3 or 4 stents sandwiched in one spot. That's not a good thing, usually for stenosis rates. And then we hopefully can prolong the dual antiplatelet therapy, blood thinners that are used for a long time, especially in the elderly population, increase risk of bleeding and also mortality. And then non-invasive techniques can be used more readily. CAT scan, CTA of coronaries, especially when it comes to metallic stents, is a problem because of beam being deflected, and maybe improve quality of life. Well, this is how the stent looks now. This is polylactic acid frame struts. It looks everolimus, which is the best drug that we know so far for restenosis inhibition. And then its mechanical properties are similar to a multi-link stent, which is 7th generation, let's put it this way, bare metal stent. However, this platform is not used anymore because it's too stiff. So there's problems, of course, with first generation bioabsorbable stents because they are thick strutted and have less flexibility to deliver. So they are usually used for simple lesions. You will see an absorbed stent called BVS, bioabsorbable vascular scaffold, instead of DES, drug-eluting stent, on the charts. And if you see that, your approach is the same as if it was second generation DES, drug-eluting stent, that is metallic. Usually a year of dual antiplatelet therapy, same other drugs. So you will not see this stent penetrate more than maybe 20% of cases, maybe even less. Even in Europe, where they pushed it a lot in institutions, 30% was the highest penetration rate per institution. Still, second generation drug-eluting stents persevere. This stent is non-inferior to our second generation metallic stents, non-inferior. The company didn't even go for superiority because it is difficult to beat second generation drug-eluting stents. The restenosis rates are less than 5%, in some hands 2% or less. Thrombosis rates are less than bare metal stents now. This is a giant now that you have to battle with really better than this technology. And talking about better than this, already a third in reduction of struts for the second generation absorbable stent, and more flexibility, as well as broader pressure working range for interventionalists, more comfort, psychological comfort included for deployment. However, unchanged is the drag and elution rate. Those stents, this absorbed stent fully absorbs in 2 to 3 years. 2 to 3 years. There's stents that absorb in weeks nowadays. There's 3 more absorbable stents in Europe on the market. They still didn't get through the barrier of 30% penetration rate. Next is mitral clip. Mitral clip is a percutaneous technique of repairing mitral valve through femoral vein, and it works very well, but for very selected patients. So you will see mitral clip patients that are usually mitral valve prolapse patients with severe mitral regurgitation, usually elderly and not very sound candidates for open heart mitral valve repair or replacement. Clip looks, clip is very involved technologically. This picture doesn't pay its, this doesn't reflect its complexity. It's a very complex mechanism. Procedure includes a system of pulleys and quite a big contraption. On this video that you will see here, we see the heart cross-sected with a ventricle. Here, blue is the jet of mitral regurgitation. This is the mitral clip delivery system. 6 knobs, each one has its own degree of freedom, so you can use the combination and factorial equation to know how many motions we can accomplish in the heart and otherwise. We go through the inferior vena cava into right atrium, puncture the atrium at a very specific spot so that we have room for our manipulations. We put a guide catheter into the atrium, take the wire out. Through the guide catheter, the clip comes in on its, let's put it this way, delivery system. Not a leash, actually, it's a delivery system. Clip can open and close to 70 degrees to 0 degrees. It's got grippers, it's got, which are like anchors, it's got, it can move in any direction in 3D space. Under the transesophageal echocardiogram, we deploy the clip. We go over the valve, position it well in the jet of the regurgitation. We dive in then, once the clip is positioned well, below the mitral valve leaflets here, anterior leaflet, posterior leaflet. We open the clip a little bit more, pull it up and grab the leaflets. They land on the clip, then we put the grabbers up, grabbers down, and then the leaflet, the clip up. If we don't like the result, and it is all supervised by TE, transesophageal echo, then we can open the clip, we can even invert it and take it out and then reposition it. Then, once we grab got a good grab. We make a bow tie out of the mitral valve. Prolapsing leaflets are stitched together, and then there's good openings still on the sides, and mitral regurgitation can be reduced to trace from severe in the selected patients. Then we let it off the leash, and then take the equipment out. The septum heals on its own since it's aggravated by direct puncture, so it's like a wound that heals with scar. And then the patients usually do very well. This kind of patients require dual antiplatelet therapy for 3 months. I don't think there'll be any new generation of mitral clip coming. I think this technology, other than maybe some little improvements technologically, has exhausted its capabilities. A very interesting technique. We've done it for a few years with very good results. Next on the agenda here is CardioMEMS device, which is a monitoring system for heart failure that we implant inside the patient. And actually they have their data on the internet secure site that you can look at from anywhere if you have sign-on. This is heart failure admissions decrease device. The device looks like this. It's about 1 centimeter long with big whiskers. We put it into pulmonary artery. It does not require a battery. It talks to a little pad that we put under the pillow of the patient when he or she is sleeping. And that device transmits information of pulmonary artery pressure. That information can be used to act before the patient gets swelling and shortness of breath increase, before the heart failure decompensates, because pulmonary pressure is the first parameter that goes up before even symptoms worsen. Then we can call the patient over the phone, say, take extra dose of Lasix, start metazolone, and so on. Decreases the readmissions rate, and that's the main caveat of this device. The device is implanted relatively simply. It might look complicated, but we again go through the femoral vein with a Swan-Ganz catheter that everybody knows here, of course, and then we go through the right heart, tricuspid valve, pulmonic valve, into left pulmonary artery, preferably posterior inferior branch of it. We find an artery that has a size of 7 centimeters or less, 7 millimeters or less, and then on this delivery cable, we deploy the device. Its whiskers catch into the artery. It's not going to move back because bloodstream pounds it in, obviously, and it stays there forever. It doesn't require battery. It's got a piezoelectric crystal that is induced by the pad on the patient's bed under the pillow, and that it takes its energy from that to transmit. And this is the transmission onto the monitor next to the bed of the patient, or onto the internet-based monitoring site. Left atrial appendage occlusions. Next technology. There's a few names here that are on the market or coming to the market very shortly this year. Those names are brand names. This is first generation devices to occlude left atrial appendage so that patients with atrial fibrillations do not have to take anticoagulation, and yet stroke and other embolic events are prevented. Left atrial appendage is the place where most of the thrombus forms in the heart and cardioembolism comes from. Thus, we notice also that a lot of patients cannot take warfarin or novel anticoagulants. They're not treated because they're not tolerating them. Well, because of bleeding problems. So for this, there is a sealing of the left atrial that can reduce the risk of stroke and eliminate the need to blood thinning medication. For now, you'll see patients with Lariat device, which is, I think, going away. So we're not going to use much time because it's too cumbersome. It's too cumbersome because it requires 2 access sites. One site is your usual femoral vein, right atrium, and transeptal puncture into left atrium. So there's an invasive transeptal puncture into left atrium right here. There's a magnet coming out into left atrial appendage, believe it or not. This is a magnet. Then we puncture dry pericardium. So there's no pericardial effusion, and there's a special needle that you can get into pericardium instead of myocardium. And then through pericardial space, we put a big tube, guide tube, with a lasso here. But before we put a lasso, we put another magnet and make a connection through the wall of the appendage. On this connection, as a rail, we put a lasso around the appendage from outside in pericardium. This is percutaneous technique, by the way. So patient is so this is just a needle stick here and a needle stick in the groin, right? And then there is a special balloon for the for closing the lasso. We close the lasso partially, take the balloon and the magnet out of left atrial appendage. Then we tighten the lasso, and then eventually we put a little catheter through here, and then cut the string after we remove the catheters. Very cumbersome, 2-access sites. We've done quite a few of those, but I think that is not as simple as the next technology that I'm going to show you now, which is Watchman as well as the Amplatzer occluder of the intratracheal septum. These require only transeptal puncture and femoral vein access, no pericardial dry tap. This is the first device, and this device is FDA approved, is used, and has been shown to reduce the stroke similar way to Coumadin in the controlled randomized trial. And that's how it looks like in myocardium, from inside out, appendage, myocardium. It's done under transesophageal echo guidance. The device, after transeptal puncture from right atrium into the left atrium in a specific place, we put a wire into the left atrial appendage. On this wire, here's the appendage. Jumping ahead of myself, here's the appendage. This is pulmonary vein where you anchor the stiff wire to put the guide in. Then there's many types of appendages. We now distinguish, believe it or not, and they have very fancy names. And basically, depending on these are actually literature names, officially. So that's what you see in the Journal of American College of Cardiology publications. And then we put a wire delivery system over the wire into the appendage, and then desheath the device with its little anchors, grabbing the edge of the appendage and closing it. The appendage usually thromboses, and for the sake of time, this is really painful. We put it in like that, and that's it. Next device, very similar concept, better device, little anchors here. It's called Amplatzer occluder. It's based on Amplatzer occluders that you've seen on your charts from PFO occlusions and ASD occlusions and VSD occlusions. Same company, same technology, based in Minneapolis, by the way. So this is our Amplatzer, and I think this one is a winner down the line once FDA decides to approve it, For this one, we don't care if this is a chicken wing or broccoli or cactus or menthol kind of appendage. It conforms because it's nitinol based. Nitinol is an alloy of nickel, titanium, chromium, and other rare metals that has thermal memory and is very flexible. And not only flexible, but a very high tensile strength. So it can conform and push. And in the 37 degrees of body temperature in a human being, it within 24 hours conforms its original shape produced, no matter what you do with it before. So it's actually NASA technology from space program. So 2 discs, you deploy them, occludes the appendage. This part that touches the blood runs through of the occluder, endothelializes fully. In fact, if you put a camera or do an autopsy, you wouldn't know there's occluder in there because it would look like healthy left atrial wall with a little nipple here left from that cable delivery through the space. And this part thromboses off. Robotic PCI, first generation robot got improved right now. There's first cases published recently on those. Robotic percutaneous coronary intervention makes sense. Robots do a lot of things for us. There is robotic nations, of course, and increase in industry, especially when it comes to production. But robots also clean our carpets and drive our cars soon enough. Tesla has this software that drives you home, and you can check your email during driving, if you're on the right road at least. So the first generation robot were the first site actually here at Sanford, commercial first site in the country, in the world actually, to buy ourselves those toys. This was first generation robot. That robot showed to have less radiation, less contrast, and the safety and effectiveness, as well as precision, were improved. Well, this is a very beautiful story. However, there was lots of questions we had when we got our hands on the robot. We, advised the company to improve on on some capabilities when it comes to movement of catheters, not just balloons, wires, stents, and other equipment. So now the robotic arm has also guide catheter software and grip, and it can move the guide catheter also. So the operator sits in a booth, either in a room or outside, without with lead protection. You don't have to have lead on, by the way, but we keep lead on just in case we have to strap in, so we can go quickly if something happens. We haven't had cases like that. And then you advance. You have your screens in front of you. Sit, which is actually very comfortable for interventionalists. It is important to have interventionalists being comfortable, because then he or she can focus on the case rather than their back. And then you advance wires and catheters and stents and balloons and take them out using joysticks, 2 joysticks plus few knobs. The robot is good because it can advance 1 millimeter at a time by push of a button. Some interventionalists cannot do it with their fingertips. So, you know, you have to advance a wire that is 3 meters long or 190 centimeters long from 1.5 meters away in the heart where it's twisted over. Some people cannot do 1 millimeter at a time. And some people say it doesn't matter. Actually, it does. Now, CTO PCI is the next topic. Chronic total occlusion, percutaneous coronary intervention. Underestimated topic. This is probably the most complex procedure we do. Not the fancy stuff that you just seen with fancy devices. This is there's fancy devices for this too. However, this requires the highest skill level for interventionalists. CTO programs have been growing around the country, but not necessarily very fast. There's dedicated interventionalists that do them for a reason. CTO, PCI, why would you do it? Complete total occlusion of dominant right proximally. Maybe patient can live with it, maybe not. Well, there's studies now showing actually that there is a improvement of symptoms, LV function, quality of life, and even survival rates increase. So these are interesting studies. There's bigger ones on the way now, 4 of them, I think. And I think this is the way of the future. Some arteries cannot be bypassed. Some patients don't qualify for bypass. Many patients have single vessel CTO, and you cannot just bypass single vessel CTO unless it's an LAD. So it's a good technique. We do very fancy stuff. I'm not going to go through the movies, but this is the right coronary artery, which is closed here. It's going to look like this when we're done with this. But in order to go from here to here, you have to go from one leg to here, from the other leg to the right coronary artery ostium, from the other leg to the left main ostium, go through left main to LAD, from LAD transeptally to distal right coronary posterior descending artery, go back with a catheter and wire and puncture distal cup here somewhere here, this way, push the wire up to this guide and take it out on the other leg, using, you know, making basically human shish kebab. So heart is on the leash, and then 2 ends of the same wire are sticking out. So now you can take the other end that you just eventrated on the other leg and push equipment this way, and this becomes, you can drive a train with this kind of support, and then revascularize antegrade, then you take the equipment backwards the way you put it in. This is a complex, successful, patients do very well. Some patients are surprised how well they do afterwards because they don't realize what kind of symptoms they had and how symptomatic they were before. CTO is usually years of symptoms that patients live with, so they think it's a norm. And then there is a few toys for us that have nice names, of course. Stingray, that you puncture back in, because actually you can dissect and go through dissection planes in a coronary and then re-emerge where you want to with a little finger here and a balloon that forms a plane for you of re-entry into the vessel lumen rather than pericardium, which is bad. And then there's a crossboss tip, which actually dissects bluntly. It's called crossboss because it bosses everybody around. And so those toys are available for the last few years, actually. Now, step back to Dr. Tali's times when he was the pioneer and started our program here. Plain old balloon angioplasty, Andreas Grunzing, 1977. Plain old balloons. We use balloons, but not as an end device, right? We use balloons to prep the lesion for stents. 20 years later, this LAD was still open with ballooning alone. Why I'm talking about this is because drug-eluting balloons are coming into the country very soon. In peripheral intervention, they are already FDA approved in our shelves. You can do SFA, femoral artery intervention, and elute on a balloon after ballooning the drug into vessel wall, paralyze the endothelium so it doesn't overreact and overgrow. And there is less intimal hyperplasia, so restenosis rates are pretty close to bare metal stents. The Europeans have this for like 3 years. Very good results. Diffuse disease in small vessels in coronaries are treated very well, and actually coronaries grow for next 6 months in their lumen. They grow rather than restenose. So good technology, something to look forward to when it comes to drug-eluting balloons. Next is percutaneous assist devices for the heart. Impella is #1 device now in the country to put percutaneously if you have cardiogenic shock. This device can deliver 5 liters per minute of cardiac output, which for a grown big man is enough to live and talk to you while they have asystole or ventricular fibrillation. They don't even know that the heart is fibrillating or in asystole. This device is put percutaneously. We've used it very successfully. There's a right ventricular device also coming in, close to FDA approval, so you can have Impella through the vein and through the artery. You put it through the femoral artery across the aortic valve. It pumps blood from left ventricle to aorta continuously across the aortic valve. Does not give you pulsatile pressure wave, but patients talk. We've done a few cases when patient would arrest during PCI and the patient wouldn't know it. They would still talk to us. And we did it in VFib and then shocked the patient after we're done. So much better than balloon pump that you are very familiar with, much better hemodynamics, and also better outcomes now. This is something to look out for. The access site is 14 French, which is twice as big as a balloon pump hole, so lots of bleeding can be expected. So some patients will not take it because of their peripheral vascular disease. And then last but not the least, maybe underappreciated, the support system for angioplasty. This is a guide catheter. In order to deliver the equipment, you park it in the ostium of the coronary artery, and then you put a guide wire, and over this system you put in the lasers, balloons, rotobladers, you name it, stents. Sometimes there's not enough support on this guide to deliver the equipment. Thus, 2 companies producing very fancy names, of course, devices that are mother and child telescopic system. Basically, instead of catheter kicking out of the cornea as you push the equipment in, you have a deep throat, child of the mother. Mother is the guide. Actually, they call the guide in Europe is called mother. Mother here, and then produces a system that is hard to beat. It is underappreciated. We've done 2,000 cases here with this system, and I think we have the largest single center experience database for this, because last publication in JACC last month was 347 patients from Cleveland Clinic, and they were very proud of themselves. Also, this month's Cath Lab Digest, the first cover page we made with triple telescopic system. We put a small guide liner into bigger guide liner into big guide, which is a triple telescopic system, and that system is extremely powerful. There's no more powerful support system for PCI at the moment in the world than this. We call it the GG, which is guideline or GG system, and then we got very good marks on that one. So that's something to look into. If you see guideliner or guidezilla on your chart on the CAT report, that means it was complex intervention. That means it was problems. And then with good sense of direction, hard work, I think we'll proceed with Dr. Tali's legacy here and persevere and enjoy patients like this. There's a 90-year-old nurse working full-time still in Washington. So. Thank you very much. Any questions? Yes, sir. Yes. Yes. It's the company is, Dr. Edwards started the company. Dr. Carpentier from France chipped in. I don't know if Dr. Edwards is still alive, but this is a big company now that produces this Sapient Edwards valve. Yes, and interestingly, the Star Edwards valve, ball and cage, not too many people walk the earth with this valve anymore. We have a patient actually in the hospital that still has this valve and still alive. Very good question. So non-inferiority means they don't occlude more often than the drug-eluting stents of second generation, which are the best there is at the moment in the world. But they are not better. There have been some instances that maybe their thrombosis rates, occlusion with clot rates are a little bit higher, especially in smaller vessels. That's why they are designated for big vessels and simple lesions. That's why the penetration I mentioned rate for first generation bioabsorbable stents is going to be lower than normal in the industry. You know, you have a second generation drug-eluting stents came in a few years ago. Out of the sudden, first generations weren't there anymore, and in 2 months they stopped producing them. Here, it's not going to happen.
And with the stuff you interventional guys can do, are there less people now going into cardiac surgery?
Yes, many less. Already, when I was a fellow, the process started when I was a fellow. That was 15 years ago, maybe. There was for first 5 years when drug-eluting stent evolution started. It was a revolution. They called it. You know, cardiovascular surgeons took quite a big hit. 20% reduction in bypass surgery in the country per year for 5 years. So when you think about your financials and compound interest, this is how it worked for them too, negatively speaking. So 20% of less, 20%. So it was a very big hit for bypass surgery.
Adam, I want to bolt a question on about the absorbable stents. So I think you told us 20-30% of the cases, there's some coronary stent cases you do.
At most, they will be. They're not yet. With second generation.
You said they reduce the need for new antiplatelet therapy. So
that was the hope.
30 days, 90 days?
Yeah, 1 year officially still, sorry.
1 year.
Yeah, 1 year officially, sorry, yeah. And then polylactic acid frame might be more thrombotic than actually matrix embedded everolimus on bare metal stent, which is the thickness of the struts also speaks for thrombosis. The less thick struts, less thrombosis, less surface area for blood to act on. So 80 microns struts in our new metal stents versus 160 microns. Whatever antiplatelet therapy you want, but 1 year, and that's kind of probably, this is new technology, so we're cautious, so we recommend, we're not going to go to 3 months or 6 months as now for guidelines for second generation.
The CHF monitor device, is that thrombogenic at all?
Actually, not really, because it endothelializes.
Okay.
So actually, you would think that this branch will close off and you have an infarct of lung there. Doesn't happen. And it's actually pretty small. It's long, but it's thin. It's like, you have to put it through a sheath in the legs, so it's really thin. Hole here. Yes. No, it's not thrombogenic. 3 months of antiplatelet dual therapy only, and this is experts' opinion only, no studies. But good question. They're not thrombogenic. We don't see strokes from it unless you lose it. It flies off. But it doesn't fly off that easy because actually you have it on the little nitinol wires. After you get a cable off and you don't release it till you know it's really home. You haven't lost any so far. Yes, ma'am.
I'm kind of fascinated with the delivery devices. It seems that each one of these products is a different delivery device, and we talk a lot about improving the product, but the delivery device has got to be just as important.
That's exactly the point. That's why my last slide was on the guideliner, and that's why we're so proud of ourselves for this Calhab Digest cover this month. Because you can talk about all you want about fancy stuff you can put in the heart. As long as your transportation doesn't work, if it's not there, it's not going to work. So yes, there's lots of interesting stuff going on. Lots of people shy away from very powerful systems because they can dissect, perforate, kill. So that's the problem. So that's why the research is relatively slow. But that's how I think we got our 2000 guideliner cases here, because cases that took 2 hours for some people take 5 minutes. Guideliner, you can drive a train in, especially with the mother-child and grandchild system of triple telescopy. There's nothing that.
One more question.
I had a question about what are your thoughts on the transcutaneous mitral valve replacement and the
Yes, good point, Jimmy. So I didn't talk about this because this technology is still away 2 years from Europe and maybe 4 years from us. There's 7 valves tried. Tiara is number 1 there, and this is like 10, 20 patients trials only. So this is, and now the percutaneous mitral valve is mostly input through transapical approach. So you have to actually open in between the ribs, the chest. Then you have to puncture with a needle apex, like we did for transapical TAVIs a few years ago, and then put your rail in, and then you can drag the valve in. But transapical procedures are more invasive, and actually there's high mortality, as you know, right? High mortality, twice the mortality than transfemoral for TAVIs. So you'd expect with mitral valve, which is way more complex entity, complex structure. Mitral valve is very complex. You only learn it when you go to cardiovascular surgery patient. Found the valve through the open left atrium. That this is not what you thought it is exactly, but it starts moving. This is really different. So that one we're 2 years away.
I think with that, then we'll wrap it up. And thank you, Adam. Thank you, everyone, for joining us today.
I don't know who else.